This is a referred case of a upper right molar with an instrument separated in the mesiobuccal canal beyond the curvature. The curvature I estimate at about 120 or so degrees. Also note the lack of a femoral distal aspect, and this does have a significant negative impact on the prognosis, but the patient was willing to accept this and chose to rather try and save the tooth. The referring dentist was kind enough to specify what type of instrument fragment it is. It is a Protaper Next instrument with an offset mass. Usually when we have a curve, straight line access is critical. We can't overemphasize that. And it's even more so in the case of the Protaper Next. I have not used these files extensively, but I have been told that they don't like double curves or S-shaped canals as much. So straight line access in this case could have probably have been extended a bit more to the mesial buccal. I did not even attempt to try and establish a visual on the fragment, because in a curve like that it would be extremely likely to perforate when we try and create a straight line access to the instrument. Instead, I tried to bypass the instrument. I used a combination of 6, 8 and 10 C+ and K hand files. A lot of time went into irrigation. I activated using an ultrasonic technique. What I did was insert a size 10 C+ instrument as far as it would go past the fragment, and then gently touch it with the ultrasonic handpiece on a relatively low setting. There was nothing for it, so we started the obturation with preheated Protaper injected into the canal. I'm using the B-fill system from BDW. It's a 2-in-1 system where you can do both the vertical condensation and backfilling of the canal. I applied as much vertical pressure as I dared. I could have overcooked it and caused the fracture, but I took extreme care to make sure that the plugger is not too wide for the canal, and there's just a little bit of Protaper around the tip of the plugger, cushioning the effect of the vertical force. It's not likely that we got cement in everywhere where it's supposed to go. It's even less likely to have Protaper sealing the root all the way to the tip. But if you look at the radiograph which I took before I applied any other obturation materials to any other canal, it does look like we at least got something right. Next image is of the other canals already obturated and the patient's permanent crown modified to fit as a long-term monitoring crown. One last remark is about the absence of an MB2 canal in this case. I think the presence of a joining MB2 canal would have made the bypass slightly easier. Thank you for watching.